Welcome back to Clinically Clear, guys. We'll be covering two more short topics. So, first, let's start with corneal opacity. Now, what could be the cause for a corneal opacity? We have congenital causes, we have acquired causes. Congenital causes is given by the mnemonic STUMPed. S for scleroderma, T for trauma during birth, U for ulcer, M for mucopolysaccharidosis, P for posterior keratoconus, E for endothelial dystrophy, and D for dermoids. Even if you remember four, it's enough. So, congenital causes stumped scleroderma, trauma during birth, ulcer, mucopolysaccharidosis, posterior keratoconus, endothelial dystrophy, and dermoids. Then, acquired causes. Acquired causes, as we know, when a corneal ulcer heals, it heals by fibrosis. So, healed corneal ulcer. Similarly, not just an ulcer, not just because of an infection you have an ulcer, any injury also, any mechanical injury, any chemical injury to the cornea, that will also heal by fibrosis, leading to scarring. So, anything that heals by scarring, healed corneal ulcer, healed mechanical injuries, healed corneal mechanical or chemical injuries. Then coming to the classification of corneal opacity. This is important. Nebular, macular, leukomatous, and adherent leukoma. Basically, if I take this as the corneal thickness, if it involves the superficial, just the superficial stroma, Bowman's membrane, and the corneal epithelium, very faint opacity, then it is known as nebular. Nebular actually causes the maximum distortion of vision. Why? Because it is so thin, light can pass through it, but it makes the bend, it abnormally bends the light, so therefore refraction is affected, hence it leads to distortion of vision. So maximum distortion of vision is actually because of nebular corneal opacity. Then you have macular corneal opacity. Then macular corneal opacity basically is a semi-dense opacity. It's more dense than nebular, and it can involve up to 50% of corneal thickness. So anything from a faint opacity to up to 50% corneal thickness is macular. Then leukomatous is a dense opacity when it involves more than 50% of corneal thickness. Almost the entire thickness of the cornea is now become opaque. Then it is known as leukomatous. Leukomatous causes the maximum loss of vision. Why? Because it completely blocks the rays. That is leukomatous. There is something another known as adherent leukoma. If the opacity gets perforated, then the iris can protrude through that perforation. Basically, the iris goes and adheres to that opacity and the perforated opacity. That is known as adherent leukoma. So these are the four types: nebular, macular, leukoma, and adherent leukoma. How do we clinically differentiate between the three? See, nebular, macular, and leukomatous, this is the three most important. There are, see, when you look at an eye, you can see microscopic features like iris details, the pattern of the iris, the color, and etc. Some macroscopic features like the pupillary margin. This is the pupillary margin. So when you talk about nebular opacity, you can still see both. You can see the iris details, you can see the pupillary margins. That is because it is a very faint opacity. Macular is semi-dense. You can still see the pupillary margin, which is a macroscopic feature, but you cannot see the iris details. Whereas leukomatous, you cannot see both. You cannot see the iris details, you cannot see the pupillary margin. How do you treat it? You treat it with optical. How do you treat a corneal opacity? Optical iridectomy is another surgery. Keratoplasty, repair of the cornea. Keratoprosthesis, corneal transplantation. All this if you want to recover the vision loss, if vision loss is irrecoverable. If it is something irrecoverable, then you just give cosmetic colored contact lenses, and you can do, some people who have like interest in getting their cornea tattooed, they can get it, they can have any tattooing done, just an opaque contact lens, so that it does not the opacity is not seen outside, but vision loss is not recoverable. This is about corneal opacity. Then coming to keratoconus. See, keratoconus is a mostly bilateral. It is progressive, non-inflammatory, ectatic condition of the cornea, where cornea becomes cone-shaped. Conus, cone. So what is ectasia? Ectasia is thinning of the cornea. So cornea is becoming thinner and thinner, and it is progressive. It is becoming more and more cone-shaped, and there is no inflammation, non-inflammatory. What could be the cause? Congenitally, you have a very weak cornea because of genetic predisposition. So therefore, very thin, weak, genetically predisposed cornea. That could be a cause. Or associated with some other conditions like allergic keratoconjunctivitis, contact lens, trauma, Down syndrome. So in Down syndrome, in VKC, allergic conjunctivitis, patient keeps rubbing their eye. When they keep rubbing their eye, what happens? They put force on the cornea, and cornea, which was supposed to be convex, it slowly starts to become cone and cone more shape. Why? Because patient keeps rubbing their eyeball. Similarly, any trauma can make it cone shape. A contact lens, if you don't wear the contact lens correctly, the contact lens can push the cornea to make it cone shaped, etc. So Down syndrome, VKC, trauma, and contact lens. When coming to pathogenesis, why does it happen? Basically, there is increased collagenases activity, decreased antiproteases activity, and decreased collagen cross-linking in the corneal stroma. So because of that, what happens? We have very, very weak collagen fibers in the corneal stroma, weakened corneal stroma, very, very thin corneal stroma. So the cornea is very weak. It easily gets molded into the cone shape. So cornea becomes cone shape. Basically, collagenases activity increases, and this thing corneal's called anti-proteases activity decreases, and there is decreased collagen cross-link. So next, coming to the symptoms. Symptoms, you have blurring or loss of vision, progressive blurring or loss of vision because of myopic astigmatism. Basically, what happens? Normally, the cornea is convex, right? So slowly it starts to become more and more cone shaped. Now, because it starts to become more and more cone shaped, the axial length of the eyeball increases. And when axial length of the eyeball increases, myopia. And why is it astigmatism? Because the cornea has an irregular shape. So, irregular shape of the cornea as well as an increase in axial length lead to myopic astigmatism. So, the symptom in keratoconus is progressive vision loss due to myopic astigmatism. Then, coming to the signs of keratoconus. So the hallmark sign is thinning of the cornea. Why does the cornea become more and more thin? The cornea becomes more and more thin because of ectasia, as I told, because of the weakened corneal stroma. Where does it happen? Maximum thinning is at the apex of the cone. Always the apex of the cone, you have the maximum thinning, and this apex of the keratoconus cone is always inferior to the center of the cornea. Is always inferior to the center of the cornea, the apex of the keratoconus cone. This is the hallmark feature. Central or paracentral thinning of the cornea. Maximum thinning is at the apex. It is always inferior to the center of the cornea, the apex of the cone. Munson's sign. See, think about it. They have a cone-shaped cornea. So normally you have your eyelid like this, and normally the eyeball is convex in shape. The eyeball easily rolls down. When we look downwards, the eyeball easily rolls along the eyelid. But let's say the patient has a cone-shaped cornea and you have the two eyelids like this. Then what happens when the patient goes for a downward gaze? The cone-shaped uh, eyeball, the cone-shaped cornea, it will bulge onto the lower eyelid. So hence the bulging of the lower eyelid upon downward gaze. This is known as Munson's sign. So Munson's sign can be seen. Rizzuti sign. When we flash a torchlight from the temporal side obliquely, what happens is, think about it, you have a cone-shaped cornea. Let's say a flashlight in this way. This part of the cone will reflect light, this part of the cone will reflect light. So because of that, what happens when I flash it from the temporal side onto the nasal half, an arrowhead shaped light reflection is seen. This arrowhead light on the nasal side is known as Rizzuti sign. So Rizzuti sign can be seen. Then when I look at microscopically, I can see Vogt striae, that is corneal stress lines, corneal breaking lines. Why? Because of thinning. I can see an opacity at the apex of the cornea. So this Vogt striae, opacity of the apex. Retinoscopy, scissoring reflex can be seen. Ophthalmoscopy, you can see oil droplet reflex. When I do ophthalmoscopy, it appears as if there is an oil droplet, as you can see in this picture. Why does that happen? The opacity at the apex of the cornea, it puts a shadow on the fundus. This leads to the formation of an oil droplet appearance, oil droplet reflex. The investigation of choice is actually not keratometry but corneal topography, keratotopography. Why? You're looking at the shape of the cornea. So here you can see a cone shaped cornea. The cone can be nipple shaped cone, oval cone, globus cone, etc. Then coming to the treatment aspect. So what are the signs? Risuti signs, Munson sign, oil droplet reflex, scissoring reflex, Vogt striae, then hallmark feature, that is thinning of the cornea at the maximum at the apex of the cone, inferior to the center of the cornea. And you have confirmatory test, that is corneal topography, where you'll see that the cone is nipple shaped, globus shaped, etc. Nipple globus or oval shaped. Then treatment. Treatment, you can give rigid contact lens. Rigid contact lens, what it will do? It will just push the cone shaped cornea into its original shape. So what was like this, when you give the rigid contact lens, it will push it back. It will push the cornea back into its original shape. But the problem is there's a chance of development of opacity in the cornea. So that is one problem with rigid contact lens. Then there's another popular treatment known as C3R. Three C's: corneal collagen cross-linking. Corneal collagen cross-linking are for riboflavin, with riboflavin and UVA exposure. Basically, when we do corneal collagen cross-linking with riboflavin and UV exposure, the cornea stroma gets stronger and stronger because of cross-linking of collagen fibers. So this reduces the progression. It prevents the progression of keratoconus. And if it is very severe, then you have to do keratoplasty, where you'll repair the cornea, or you can do corneal transplantation, keratoprosthesis. So, treatment: rigid contact lens, problem is opacity. C3R with UVA exposure to prevent progression, and keratoplasty or corneal transplantation to, if you want to, if it is a very severe case. That is it for this video. I hope you guys enjoyed it. Thank you for watching.